Welcome to the Woodland, everybody. I'm Simpson. I'm delighted to be chairing this live panel discussion here in Nottingham, which is taking place before the 22nd Annual International Web Network for Psychiatric Nursing Research Conference, otherwise known as the NPNR. Over the next 2 days, mental health nurses, service users, academics, researchers will be meeting to discuss mental health across the life course, covering everything from perinatal, I knew I was going to mess that one up, perinatal mental health to dementia, with talks on child and adolescent research, postnatal depression and adult crisis care along the way. This live streamed event is a collaboration between the NPNR conference, the mental health, and we mental health nurses. The meeting is going to be divided into 2 segments. The first hour will be a panel discussion, and then at 7 p.m. that will be followed by a tweet chat hosted by the lovely Mark Brown from We Mental Health Nurses. Please get involved on Twitter via the hashtag WeMHNS. Your comments and questions will be relayed to our panel, who will stick around until 8 p.m. for the whole tweet chat. The discussion this evening aims to whet your appetite for the conference. We've invited 4 of the speakers to talk about their chosen area of interest. First up is going to be Professor Wendy Cross. Wendy is Associate Dean of Nursing and Allied Health from Monash University and also President of the Australian College of Mental Health Nurses. Wendy will speak about cultures and attitudes in acute adult inpatient units, implementing significant cultural change and the responsibilities of nursing leadership, especially among those who direct and manage others on a daily basis. After Wendy, we'll have Elaine Hanzak. Elaine is the author of a number of books, most recently Another Twinkle in the Eye, contemplating another pregnancy after perinatal mental illness. Elaine will briefly outline her personal journey of interest and expertise around perinatal mental health. She will expand on the impact that goes beyond just the mother and explain how perinatal mental health is relevant to psychiatric nurses across the lifespan. Pryjmachuk is Professor of Mental Health Nursing Education at the University of Manchester. Stephen's going to talk about how very few nurses are involved in research in children and young people's health and what we can do to try and encourage more nurses to become involved. And finally, we have Dr. Lisha Rennick, who's a lecturer at the University of Manchester. Lisha will talk about the history and development of early intervention services. She will cover the new access and waiting time standards and will also focus on physical health, mental health and parity of STEAM. So lots to listen to, lots to get involved in. Don't forget you can ask the panelists questions by tweeting it to hashtag WeMHNSS, so it's WeMHNS. And at 7 p.m. we'll be handing over to Mark Brown, who is leading the We Mental Health Nurses tweet chat this evening. Please do join in with us at WeMHNS. We'd love to hear your response to what you've heard so far. And we'll all be joining them on Twitter later on. So let's get the discussion underway. Wendy Cross.
Thanks, Elaine. The topic that I'm going to talk about this evening relates to leadership, but it's in the context of the paper that I'll present tomorrow, which is about smoke-free units and the ways in which or not in Australian inpatient units. This is a student project of a student of mine, and it was a very interesting project in that she was charged by her health service to implement the policy, the smoke-free policy, in their inpatient services, and was given the role of champion for this particular project. The problem, of course, with champions is that you need to have people who are following along, and this is where leadership is absolutely crucial. So, smoke-free policies are controversial. I know they're controversial here, they're controversial in most places, and so the attitudes and the cultures within the units had a huge influence on the success of the implementation. 2 units were involved, both very similar in terms of size, workforce, skill mix and all of those sorts of things, but they had quite different outcomes, and it was all based on the attitudes of the nursing staff in terms of implementing and enforcing the policy. So whilst this sits around smoke-free policies, it has the same resonance for any policy that needs to be implemented where nurses, because they're largely the people that implement these things, are not on board.
So much of it is about the attitudes of nurses.
Attitudes, culture and the leadership. And it's not so much the leadership of the, what we would call a nurse unit manager, but the leadership, or the charge nurse, I think you call them here, because that person's dealing with much bigger issues, budgets and all of the other things, workforce and so forth. It really comes down to the person, the nurse, who's in charge on a day-to-day, shift-by-shift basis, and how they help other nurses to enforce or to implement and encourage consumers to quit smoking. Now within that, the focus of the research was about the leadership of this group of people, because every day they're leading over 8 hours, and it becomes the remit of that particular group of people and how they influence other nurses within that in that space. And so it's really important that we examine how we lead, particularly in controversial policy areas such as smoke-free policies or any other policy for that matter that nurses don't particularly hang on to. And the research looked at the educational needs, the informational needs of staff, the ways in which consumers themselves need to be engaged and how we might utilise those, and the role of what might be called a champion in a service that is charged with the responsibility but given limited resources to do it, and that person feels that they've got the sort of Damocles hanging over their head when things just don't work out as they would hope. So the other thing, of course, is the availability of other resources to the nurse in charge of the ward. And I'll give you an example. For example, if we just take nicotine replacement therapies, at this particular health service it requires a medical practitioner to make the prescription for that. That was absolutely diabolically difficult, particularly when people were coming in over the weekend or late on a Friday night or even after hours at any time. And so the policy needed to be amended on the hop, if you like, so that nurses could actually do the prescribing. And
so you had people coming onto the ward who weren't being allowed to smoke but had no access to replacement.
Yeah. And so that led to nurses being concerned about their levels of safety in terms of additional aggression or agitation and how they would manage all of those sorts of things. And then there are just simple logistical issues, and that is letting people off the ward so they could have a smoke off the premises, or managing staff who just decided it's all too hard, let them go outside anyway and smoke to their heart's content. So you've then got to deal with those issues as well. So, and then of course logistics of bringing people back to the ward, opening doors, closing doors. We have the units are locked, unfortunately. So then checking for contraband, removing contraband, all of those things which just add to the whole inconvenience of it. So when you've got nurses who don't already, they don't think the policy is going to be great, when they've got so many more imposts, it just is a disaster waiting to happen.
Thank you very much, Wendy. I'm just going to ask you one question before we move on to Elaine, which was there any evidence that nurses' own smoking behaviour was related to those accidents?
We deliberately did not pursue that. Because the student researcher was in fact known to all of the participants in the research. She actually knew their smoking status. But we decided that we wanted to look at attitudes, and we didn't necessarily want to sort of colour that to whether they were smokers or not, because a number of people who are smokers are also hoping that these sorts of policies will enable them to quit as well.
Absolutely.
So no, we didn't pursue that.
Okay, thank you very much, Wendy Cross. Elaine Hanzak.
Thank you. I'm absolutely delighted to be among such esteemed company. I always am, as somebody who really, my profession is as a teacher of children with severe and profound learning difficulties. And I admit that I used to think mental illness was something that happened to people not like me, because I write lists. very efficient, very organised, and I've learned through experience that mental illness does and can affect anyone. You don't have to be a certain type. Most importantly, you can get better. So I'm very grateful to be the product of the research and then the subsequent care of people like yourselves, that here I am today talking about perinatal mental health. Perinatal seems to be now the term that is used. I'm really pleased because it covers both antenatal and postnatal mental illnesses, which is great because I think in almost up until the last 2 or 3 years people talked about postnatal depression, yet as we know there's a range of illnesses that can affect women both antenatally and postnatally. Sometimes people say, I'm just a psychiatric nurse, or I work with older people, what's this got to do with me? And the more I've learned about it, the more I've realised it's not just about the mum. It can affect the infant, the unborn child, the parent, mum, dad, partner, the rest of the family, the siblings, and also for the mum later on in life. So who am I to talk about this? As I say, I was a school teacher, very much always wanted a baby. That was my big ambition in life, was to be a mum. Went through pregnancy, and I was probably one of those annoying women who read all the books, knew exactly how big the fetus was at 23 weeks and all of these things, had my plans to perfection. Sadly, the birth didn't go to plan. I was very, very ill, and I was told afterwards I should think myself lucky. Had it been a home birth of 20 years earlier, I would have been dead. From there, my son didn't sleep. When he was 4 months old, he was really ill with suspected meningitis for 10 days when I was supposed to be due back at work. As the weeks went by, I spiralled into postnatal depression. And yet, even though I had initial treatment in the community for it, I continued to believe I wasn't the type. And put on the mask of, I'm fine, I can do all of this. And within 3-4 months, I was actually diagnosed with purple psychosis. I walked the streets in my nightie, I self-harmed, all of the things that the previous me would have almost scoffed as, don't be so stupid. It happened to me. I then had 2 months as an inpatient, and listening about smoking made me smile actually, because as a non-smoker I actually envied the people in the smoking room because they always seemed to have the best time. I was left on the outside with the elderly patients doing jigsaws, and I think it's the only time in my life I've ever thought that I wish I smoked. But I did get better, and at the time I was amazed I'd been so ill, and people who knew me equally were shocked. So as I wrote a book about it, which came out in 2005, simply to explain initially therapy for myself and for the people around me who said, I don't understand it. That led to me being on national TV. I was asked to do conferences and lectures, and I've never actually been back in a school classroom ever since. And I've spent the last 11 years being involved in things like that, so consequently I've learned a lot. And because I've shared my story so openly, people have given me the honour of sharing theirs. And one question that has cropped up so many times is, what do you do next time round? I didn't have another child, and I would have dearly loved one. But what I've actually done is pulled together a basic survey of about 100 families, asking them what have they done, looked at all the latest research, the development, the good practices, and pulled that book together, and that came out last year. So this now is a new start really for me, hopefully sharing that knowledge with people. And in the context of this conference, it will be about helping people identify, maybe if they work with children, what signs could they look for? Maybe are they working with young men who recently have had a child? Maybe they're working with a menopausal lady for whom all of their postnatal history can actually come back and on itself again. Looking at some of the services, maybe some of the treatments that they want, but overall feeling that perinatal mental health is actually everyone's business. And really as an aspect of gratitude, because without people like you, people like me wouldn't get their lives back again.
So you're going to be talking about this at the conference tomorrow?
I am, yes.
Okay, we're looking forward to that. Can I ask you, your period in hospital, what sort of things do you feel helped you the most?
I think initially it was that scooping up. I'm all for care in the community. I think when your mental capability has diminished to such an extent. Even being asked, do you want to drink tea, coffee, milk, sugar, is too much of a decision. You need to be said, oh, Elaine, it's time for a drink it.
Someone needs to take over at that
Yes, totally. And I think that in the first aspect was the most important thing, because even I felt just sitting in my home environment, there was too much to do.
Yeah.
I felt everything was too much. So I needed, for a short while, just complete responsibility taken away from me. And then ultimately it was actually ECT that I felt was the biggest impact for me. Yes.
Okay. Well, it's very nice to see you all recovered.
Yes.
And look forward to hearing you tomorrow.
Thank you.
Stephen Pryjmachuk.
Well, I'm just going to give a brief summary of my keynote lecture on Friday. I think the most salient observation in one of my specialties, which is children and young people's mental health, is if you actually look at the services that are provided, nurses are the biggest occupational group, but they're barely visible in terms of research. And I think there's a connection to what Wendy was talking about, leadership. So in my talk, I'm going to give some examples of some research that is going on and being led by nurses, but I'm also going to raise some questions really about leadership and what are the barriers that prevent mental health nurses who work in children and young people's mental health taking the initiative and leading in terms of innovation, in practice and in terms of research. I will name check some colleagues because I think there are some nurses who are leading in researching children and young people's mental health, and there's some leadership in a variety of different environments. So my own interests are, I've worked with school nurses in the past. I've done some work looking at self-care support, self-management in children and young people's health. I've worked with Ben Hannigan and Nicola Evans at Cardiff looking at risk in inpatient children and young people's mental health. And some of the examples I'll give will really cut across all tiers in children and young people's mental health, all areas, primary, secondary, tertiary care. I could be negative about the whole thing and say, well, look, no one's doing anything about it. Why aren't people doing about it? But what I thought I would do is do a little bit of group or wide mentorship. So I'm going to give some advice and guidance to colleagues and people who are interested in doing research in the area of children and young people. Just some things that I've learned from my own experience about how to do it.
That sounds really interesting. That's on Friday.
It is, yes.
So what attracted you to this area of work?
It's weird really, because I never thought I would ever work with children. And when I was, of course this is typical of many mental health nurses, and I got a placement in a children and young people's unit. And first of all I loved it because I could wear jeans. And secondly, working with young people with mental health problems is absolutely a fantastic environment in which to work, and there was so much humour around, and I'm talking about humour because these kids are actually very astute and wise, challenging, entertaining, and it was good fun, and I think that has to be part of what work in mental health is all about. And I fell into it and got a job as a staff nurse, and it's
interesting how we get drawn to different things. My experience of working in an adolescent unit in my training was that it was terrifying, and those very things that you've talked about, the vibrancy of it and the intelligence and everything, I did find quite scary actually. So
I think I'm a little bit of a child myself, which helps. I haven't grown up yet.
Okay, and you hope to see more research going on in this area, and more nurses getting involved.
To be honest, it's an area that's under-researched, and I think there are a lot of opportunities for anybody who's interested in doing research in this area, and I don't see why nurses can't do it. And my own personal experiences, there are all sorts of myths that are thrown at. I was told when I was sort of getting into research in the first place about, getting a project that was yours. So I got a National Institute of Health research grant where I was PI. And people say, you'll never get one of those if you don't have a professor on the panel, or you don't have a professor as a co-applicant. And you're thinking, well, I wasn't a professor at the time, and there were no professors on the application, but we got the grant. We got the grant because it was a good grant.
It was a good bid, yeah. Yeah,
So
good
I think hopefully there'll be quite a few things that people can learn from my own experience. And I'm
Okay.
looking forward to sharing it.
Well, we look forward to hearing it. Okay, thanks very much. Stephen and Leisha Rennie.
Right, well, I suppose I've given myself a fairly lofty task
Yeah.
of talking about, what is it again?
whole host of
Intervention
things.
in psychosis.
Yes, the history and development of early intervention services, new access and waiting time standards, focus on
Right.
mental health, physical health and parental esteem. There's plenty there.
So I'll just start with the last bit first, just to tell you a little bit about that, because that's what my talk is going to be about on Friday. I'm going to be discussing physical health in people with first episode psychosis. So what I did was I looked at what people's evaluations of their own physical health were and compared them with clinicians. This is mostly for my PhD work, but I suppose it was on top of a lot of other work that I was doing in early intervention and psychosis. But what we found was really, really interesting, and there's quite an issue about parity of esteem at the moment in the I suppose politically and in the press as well, that people with mental health problems are also getting the same kind of treatment for their physical health issues, and there's a lot of stuff around that. So what we found when we measured people's mental health and when they measured their physical health and when we measured it was that we were far more optimistic about their mental or their physical health than they were, which is quite surprising, because you would assume that people often assume that they don't recognise that they have physical health problems because they naturally or seem to choose unhealthy lifestyle behaviours such as smoking, eating foods that are unhealthy or maintaining very sedentary lifestyles. So people assume that they don't think that their physical health is bad, but they do. And one of the points that I tried to make on Friday is really about how we as clinicians need to reconcile or harmonise our views with those of the people that we're looking after in order for them to get the best treatment.
So was your impression then that people were aware of things that they were doing in their lives and the impact that was having on their physical health? And were they also saying, well, I want more help with this? Or?
We didn't ask that question, but there is an issue about when you ask people, just to be very frank about this, when you ask people with psychosis, there's an issue about insight and about whether they do actually recognise that there are certain difficulties going on.
Yeah.
And perhaps in the very acute stage, you might recognise this, that can be a little bit impaired. But overall, people are able to recognise what's going on in their lives, and they're able to make judgments about what is and isn't good for them, and they're able to make plans for their health. So they do need to be enabled to do that. So I don't think insight is as much of an issue as people think it is.
Okay. So you're talking about that on Friday? That's going to be very interesting. It's a big area of interest now, isn't it? Got a lot of policy attention.
Yeah.
There's more research money going into this whole issue.
Shall I just
do.
give you a little bit of the background of that? Is that early intervention in psychosis in this country has been going, I suppose, has been going strong and waxing and waning at times, but going strong overall for about 30 years since since that seminal study in the 1980s by Eve Johnstone, where they found that people were waiting very long times to access care. 1 in 4 of first admissions were waiting more than a year, and they were having between 4 and 9 contacts with healthcare professionals or professionals that could have, or other professionals that could have helped or could have conveyed them into treatment. So that was, people thought, a major issue, and really was a major player in developing the services in the UK. So there was a national programme that rolled out, I think in about 2001 to about 2010, and then I suppose when they measured it in 2006 there was 118 teams set up nationally. What we found after that national programme kind of receded was that the budget started to dry up a little bit, and as the budgets dried up a little bit, the people were losing resources, teams were losing resources, so there was quite an issue about maintaining the services at the level they need to be maintained at. Hence, certain national surveys by Mind saying that, you know, people with psychosis were the lowest generation, that up to 50% of teens were having difficulty funding the services. So there are now a new wave of reforms called the access and waiting time standards.
Yep.
Because people were still having difficulty accessing these services, comprehensive psychosocial intervention and integrated services, people were still having difficulty. So they came into effect in April 2016, and a lot of services are now getting further funding in order to try and meet those targets of getting 50% of people seen within 2 weeks, seen and assessed, and offered nice concordant treatment.
Yes. Okay. Can I just pick up on it, Stephen? The stuff you hear in the media is that this issue of long delays for people to get support is a particular issue for children and young people. Yeah.
I mean, one of the interesting things about that is it's and this is why you can get a little bit sceptical about every new announcement is, and I'll report some of this in the keynote on Friday. Is there seems to have been a review or reporting to children and young people's mental health every 5 years, about one every 5 years, some investigation or official report, and the conclusions are always the same. The services are inaccessible, they're not children friendly, they're underfunded. Yeah. And everybody says they're going to do something about it. Yeah. And so there's always a bit of a excitement and a buzz about it, and then it sort of tails off, and then something new crops up and becomes the new crisis. So, you know, we're at that peak at the moment where there is a lot of concern about children and young people's mental health. And but what I suppose the question is that real concern, or is it just rhetoric? Because we've seen a lot of the rhetoric in the past, and it's like with any issue, you've got to wait to see if the government and the providers and the CCG start to put the money where the mouth is.
Wendy, in Australia, there are similar challenges faced for access to services?
Yes, across the board, not just for young people, but also for adults and older people. There seems to be quite a lot of closed doors throughout the system. But in Australia, we've got the renowned Pryjmachuk. You may well have read some of his work, and he became Australian of the Year a couple of years ago, and might be more than a couple of years, time does fly. And that actually highlighted quite a lot of the issues around early intervention of psychosis and the plight of young people in the system, wherever they might be wanting to access it, and not only that, I think the other area that we need to be particularly mindful of is the needs of parents in these situations, because they're the ones that will be really seeking service help, and they're not necessarily given the best options or access to the best options.
No. And not just parents. I know that one of our master's students at City University looked at access to child adolescent services for people looked after children who had mental health problems, and she found that they were getting assessments quite quickly, but then enormously long delays for access to treatment after that was a big problem. And as you say, adding significant pressure to those people looking after those children. Leisha, I might have cut you off a bit. Do you want to say any more about what you?
No, I don't know. I think about. I think just in terms of I think I've covered everything. I suppose apart from one of the major issues in the access and waiting time standards, I think is around this ultra high risk group that are now going to be included. So services will be offered for people who are suspected of being at risk of developing a mental illness, a serious mental illness. So that's quite a turnaround, really. Okay. And it's also going to be provided across lifespan, so to people up to the age of 65, and this has changed in the NICE guidelines. Okay. So, fitting with the conference title, it's about providing care across the lifespan to children and young people and up to 65.
I was going to say, you do tend to wonder though about access and waiting time standards, because they're not new to physical health, are they? You know, in lots of different areas they've always had those. Yeah. But then you look at what's happened in physical health and you think, what actually is the consequences if you don't achieve those? Yes. So, you know, this is we're in a position that seems to be that everybody thinks we have to do this and this is the right thing to do and we can set some standards, but it goes back to what I said before, is we have to see what the actuality is. And you know, I'm not in any way knocking the fact that these have been picked up, because it's quite, you know, you do some, we talked about palliative esteem a bit, but if you think about the sort of waiting list that people would have had in terms of in early intervention, if you'd applied that to a physical health condition, there'd be outcries about waiting a year before you got access to any treatment.
And also about the physical health problems that people experience, and the fact that they don't get the proper screening and they don't get illness, physical health problems being recognised by clinicians is quite problematic.
Okay, so thank you very much, Alicia. So that's a good introduction from our 4 speakers, and they're all going to be presenting over the next 2 days at the NPNR conference, along with a lot of other people. I've been attending the NPNR conference since 1999, and it's a cracking event, very friendly, very warm. I've learned so much from coming here over the years, and met some great people, and ended up working alongside many of them. So I'm really looking forward to it, and this has been a nice start to the event, a new idea and a very welcome one from my point of view. And I'm hoping we've got people out there who are listening to this and tweeting in their questions and queries and suggestions. So anything you want to throw our way, Ben?
Shall I give you one from Elizabeth Collier?
Yes, please.
So Elizabeth works at the University of Salford. She is a mental health nurse academic there. She says, how does the choice agenda fit with what Elaine said about needing nurses to take over? Choice is an illusion, she says. Small tweet, big question.
There we go.
She's followed that up with, if nurses had offered choices, which we assume is good practice, would that have been detrimental to Elaine's mental health?
These are good questions. So that's Elizabeth Collier,
Yeah.
who herself will be presenting at the NPNR, a long-standing attendee. So good questions. Any thoughts on that, Elaine?
I think when I was first admitted to the inpatient unit, I knew I just needed to be told, do this, do that, because my brain was in such a mush, it really couldn't function at that level. And I was very grateful for people to just do to me what needed doing. Looking back on my story, what could and what people have said is that there were other things that could have been done that mainly sleep deprivation, I felt, was the thing that really took me from postnatal depression to being psychotic. And maybe the weeks and weeks that I've been saying to the people involved in my care, I'm not sleeping, I'm not sleeping, I'm not sleeping, as opposed to being told, we'll put you down for the sleep clinic in 6 months. That's not good enough. So I think it was earlier on that maybe those choices, when I was in a position to take and make them. And I also acknowledge that my own responsibility as a sufferer, that looking back, if I could replay it, there were things I could and should have done differently myself, which was asking for help instead of pretending to be superwoman with my knickers on over my pants saying I can do it all. I surely couldn't.
Sure, thank you.
I think we as mental health nurses have to be experts at squaring the circle to some extent, because I know from one project that I was involved in that the sort of feedback that came from children and young people and the literature and parents is that, you know, we want choice and flexibility, but when you look at the hard evidence, they don't have any choice because they have to have nice approved interventions, and those interventions are largely behavioural or cognitive behaviour with a manual, so you can't be flexible with them. So, you know, we've got an environment where you've got sort of opposing points of view, and that, I think that's one of the sort of key elements of being a good mental health nurse, is knowing how do you square the circle when you're faced with those opposing situations.
I wonder what you think about advanced directives, though. I mean, you wouldn't have been in a position when you were unwell to have even considered them.
No.
But I suppose that is one of the questions that Elizabeth's asking, isn't it? You know, is there a place for those? And do they work?
Yeah, I think there's a middle ground.
Yeah.
Because I think the notion of choice goes to what Alicia was saying before about people do know quite often, in your case, it was in your early days, you really needed some containment, and that's the strength in the nurse.
Yes.
To able to identify when a person needs to be contained and when they need to be able to make the choice. And at least now when we talk about choice, we are acknowledging that many people who use mental health services can make choices, are capable of making choices. It's just that when we have good mental health nurse intervention, they can actually identify when choice is not going to be the right thing. It's going to be when they need to make a decision for. And even when you were talking, Elaine, I had this notion of that very, very old movie that was made by Hildegard Pepler. And you may or may not have seen it. It's about Trudy and Trudy's ability to make choices and not. And early in her history, she was unable to make choices, even to whether it would be cordial or something else.
Yes.
So simple as those sorts of things. So the middle ground is that we're acknowledging choice for people, but I think good, solid mental health intervention is what's required.
Yes,
Good assessment, decision making.
There is undoubtedly, though, a tension, isn't there? That you were talking about mental health nurses knowing when to contain, and we do that hopefully with the best of intentions, but there will be times when service users, patients say to us, well, that wasn't right and I didn't want that. And contrarily, very often with hindsight, people say, I'm glad that happened at that point, but getting that right is difficult. And I wonder if part of the issue around choice, and sometimes taking over, sometimes containing and controlling even, it's also about how that's communicated, which is part of that whole way of working in a recovery focused way. It's how that's communicated and explaining to the person what's going on, and that increasingly over time encouraging that person to take choice.
Yes, definitely.
And regain control.
Yeah. I mean, as my recovery started really from that point, I did actually want to take that ownership and want to do more for myself, but just at that first week, I would say, when I was first admitted to the inpatient unit, I was in shock, I was distressed. It was Christmas week, I'd been separated from my baby because I'd been told I'd chosen the bad time, it was Christmas. So I was admitted to a general psychiatric ward, and so that choice was one that was taken away from me, which in hindsight I would have much preferred to have kept my son with me. Yet I realised that I could not function. I had begun to self-harm, I was walking the streets in my nightie, I needed severe care. And in the same way initially that had I been involved in a road traffic collision, at that point of crisis, just do it to me, whatever needs doing, and a bit later on, encourage me and push me.
Okay. Thank you very much. I've got Ben Hannigan and John Baker in the background here, frantically reading all the tweets coming in. And Ben, or John.
So we've got a question from Paul French on a train back from London. He wants to know what we would consider research priorities for the HTA from you as a panel.
Okay.
No.
Okay. Total leap in
Is
a
he
new
on the
direction.
panel?
It sounds like he's just been
Is he on the panel?
Okay, so Paul French from a train.
Well, I can half answer that to some extent. One is that I have some research that client's event, which I will present on Friday. So, but I think as well there are some other, there are. What I would say is I think a lot of the research priorities have, to some extent you're asking the wrong people. We need to be asking service users, and in my field we need to be asking young people and parents about what they think are the research priorities.
Okay, thank you, Stephen. Alicia?
Funny you should mention it, I'm actually just about to embark on a research prioritisation exercise.
Okay.
Asking service users and not researchers, service users, their carers and clinicians, what they think are the priorities for early intervention psychosis specifically. But my own personal feeling is that we really need to be focusing on things that matter most to people, such as functioning, longer term functioning, and how they kind of achieve their normal milestones. So things like, getting on track with their relationships, education, employment, things like that. And I think from the research that I've done previously, I think that it's clear that patients or service users do not expect this from services. They don't realise that that's what services can help them with, and they don't engage with it, yet it's the thing that they ask for quite a lot. They prioritise it. I want a job, I want to be included.
Yeah, okay, thank you, Alicia. Wendy, any?
Well, I'll have
research?
to acknowledge my ignorance, and because I don't know what HTA is.
Health
What that is, I might be able to answer.
technology assessment. It's one of many streams under the National Institute of Health Research,
Right.
which in the UK is the primary funder of health research.
Yes. Well, I do some external review for the National Institute of Health Research, so I'm familiar with some of those things, but I just wasn't quite sure about that acronym. Look, I would say that any priorities for research need to be developed in consultation with a broad range of stakeholders, whomever they might be, because you've got funders, you've got service users, their significant others, families, all of those sorts of things. You've got the education system feeding into the health system, the nexus between all of those sorts of things. You've then got the priorities of the higher education system with regard, you have a ref here, I believe, we have an ERA with the same sort of stuff. So whichever way we go with regard to research priorities, it needs to be in consultation with all the stakeholders involved.
Thank you. Elaine, would you like to add anything?
When I was actually pulling together the content for my book last year, I looked at a whole range of the research around perinatal mental health, and there are some huge gaps in there. And I think coming at it from the service user's perspective, it always amazes me how many women, like myself, are keen to talk about this afterwards. That it's not something that they want to put behind them like appendicitis or something. And I think one of the key things is that this growing sisterhood is that you don't want it to happen to anybody else. So that in itself implies there's prevention here.
Yeah.
What is it that we can actually do to minimise? And that's why with this concept of next time round, if you had a very tough time first time for whatever reason, let's look at ways that next time round it can be better. And I think I would like to see more research into the impact of that, because we were talking before about financing and the funding for all this. If we get the research behind that to say, okay, let's have more preconceptual counselling services, for example, get those in, longer term it's better for the unborn child, the baby, etc., etc. So there are other areas, and I will mention those again tonight.
Okay, thank you. Well, I'm going to flag up one before I go to another question, which was we're going to be presenting this at the NPNR conference. So we had a nurse who pitched, we had a number of people who pitched research ideas to a panel of service users and carers at last year's NPNR, and we've been developing the winning candidates proposal, which was to look at safe and effective practice in the intramuscular medication, long-acting injections, and we'll be presenting how we've been developing that. So that was about prioritising an idea that resonated with a group of service users and carers, so we'll be talking more about that.
And I can also just say that they've also been helping with the losers.
Them seniors and losers. Ben.
Okay. Here's a question from Vanessa Garrity. So Vanessa is a mental health nurse who is very much associated with the We Mental Health Nurses Twitter community. Here's Vanessa's question, which takes us a little bit back to the first question actually, so forgive me. Vanessa asks, how do you offer choice and flexibility while following NICE guidelines as a mental health nurse?
With a lot of skill. I mean, I think when we were doing this, we were doing research on self-management in children and young people's mental health, and one sort of our case sites were groups using a particular type of parenting called Webster Stratton parenting, produced by Caroline Webster Stratton, an American nurse. And it's got a really good evidence base to it, but it's very rigid, really rigid. You know, it's almost like Caroline Webster Stratton has to supervise everybody who does it, and she has to have oversight of everything, and there's a manual for every element of it. And what you sort of talk to the people who are delivering it, and they say, well, if we did it like that, we would never get anybody to stay in the intervention. So So, you've got canny mental health nurses who are thinking, this intervention's got some evidence base. We actually want these individuals to stay in the programme.
Yeah.
But there's a problem if we adhere rigidly to the manual. So they change it slightly.
Mm-hmm.
And then the issues come into what do you say about when they're looking at I've forgotten the term for it, where you're checking to see that you followed the manual. Fidelity on there. So you've got a fidelity score.
Yeah.
And I suppose in having those discussions, what's made me a little bit, I'm a little bit sceptical now about how honest people are in discussing their fidelity, because I think it's a really, really good question, because I think it's one of the things that we have to try and work on, and it's one of the things that is the skill of a mental health nurse.
It's a real challenge, isn't it? Because one of the criticisms of mental health nursing has been that we haven't been very good at following evidence-based practice and implementing it. And many, for example, health psychologists are critical of mental health nurses who say we are too flexible, we take bits and pieces from different approaches and models, and that's the counter to the flexibility argument, isn't it? Alicia, what was your
I suppose we're dealing with a whole group of people that are more kind of enlightened consumers, and they are asking for evidence-based treatments and interventions of us. And I feel that responsibility. I feel the onus is on me to provide that. And there may be people who think that it's formulaic because of NICE, but I do feel that a responsibility to be providing that kind of evidence to be providing treatments that are backed by evidence. I think that there is some choice within the NICE within NICE treatments. I mean, certainly there's just the choice not to be involved at all, which does happen. But then people do get some choice of different treatments, and they do get the choice of working on different goals, or different areas of their life that they want to improve, or that they feel is an issue for them. So I do think that there's a degree of choice.
I suspect quite a lot of service users listening to this discussion think it'd be nice if I was offered NICE recommended
That's the issue.
interventions.
Yeah, I think that's the issue, that people aren't being offered it.
Yeah, Wendy, any thoughts on this tension?
Well, it's an interesting thing about evidence, isn't it? Because, best evidence is RCT and various other things, highly unlikely to occur in many mental health settings. So we have to use the best available evidence. And really the application of the best available evidence has to be acceptable and applicable to the audience to which it's being applied. And if it's not acceptable or applicable, either by service users and the people that are important to them, or by clinicians, and I'll use that term more broadly than just nurses, because the guidelines apply to everybody, then people will pick and choose the bits that they find that are applicable and are acceptable in terms of that. So the evidence in and of itself, I think, isn't the whole story. I think we just have to say that a lot of evidence doesn't exist in the work we do.
I wonder as well, it's part of the challenge for educating and developing mental health nurses, that it is about helping them to know and read and critique available evidence, to apply it to their work, but also to be able to communicate to service users, patients, families, carers, why they're offering particular interventions, what the evidence is to support that, what some of the difficulties might be. And given people that, going back to that choice agenda, isn't it? Here's something we can offer, this is why we think it would be useful, based on very good evidence.
I think one of the areas of choice that a lot of mums have spoken to me about is around medication and perinatal mental health, because certainly on the information and the knowledge side of it, there's still a very big gap in what people feel they should or they shouldn't be taking. So, for example, a lady who's had long-term mental health conditions gets pregnant and instantly feels she should come off a medication because she believes it's bad for her unborn child. And even, GPs will also, or may also say, oh, you should better stop it. And then they're wondering why that lady's mental health suddenly deteriorates. And then there's a confusion as well that once a baby is born, what medication should they not take with breastfeeding? And sadly there have been cases of ladies taking their own life and that of the babies because it's been shown that it was actually a change in medication. So that's a huge aspect around choice for that. And yet there are some ladies who may be mild, moderate depression or conditions that there could be other alternatives. And rather than feeling I take my magic pills and everything will suddenly be all right, but what are the other things? And again, that's down to the education and sharing of knowledge on that.
And of course, for staff to be able to have those conversations with people, they need not only the knowledge and information, but they need the space and time to have those meaningful conversations. And that's where, again, another tension often is for staff. I'm looking in the direction of Ben and John. See any other questions coming our way?
There's one from Michael Coffey.
I've heard of him.
Yes, so Michael is an associate professor at Swansea University. And Michael's question to the panel is, how do we maintain opportunities for recovery as services are withdrawn, reduced or otherwise prioritised?
There we go. Michael Coffey from Swansea. How do we retain, what was it again? How do we retain?
How do we maintain opportunities for recovery as services are withdrawn, reduced or otherwise prioritised?
Yes. A political question from Dr. Coffey. Any thoughts?
I think you're right, Alan. It's a political question. I mean, one answer to it is maybe we should be getting political. Another answer that's less controversial maybe is I think one of the key things about good mental health nurses is creativity, and I think if you know, I'm a mental health nurse and obviously got a lot of colleagues and know a lot of mental health nurses. There's a huge amount of creativity in there, and I think it relates to the talk I'm going to do on Fridays. It's just, why doesn't that creativity get transformed into innovation? You know, it's probably, you know, there are some elements of confidence perhaps, or leadership elements in there, but you know, the world is changing around us and we maybe have to do things differently to the way that we've done them in the past.
Alicia? Thank you, Stephen.
I suppose I just feel that perhaps how recovery is defined by different stakeholders is a big issue, isn't it? Because I think that personal views of recovery, sometimes people who are involved in services feel that it has nothing to do with services at all, that they're recovering, and that it's a personal journey, it's a personal issue. And when we talk about recovery, we talk about clinical recovery, we talk about managing symptoms or getting on top of them and looking at evidence and providing interventions for that, and we talk about kind of looking at other domains of outcome, and that's how we kind of define recovery. So
when you say we, who are you referring to?
So I mean clinicians, I think, and people who are working in mental health services, that we aren't always talking the same thing.
So you don't think mental health clinicians are embracing the modern approach to recovery, which is a more personalised, I think, social integration,
well,
achieving personal goals? You don't think they're
not necessarily, because I think both things are quite important. I do think it's important to help people with their illness, but it's also important to infuse nursing with the creativity that Stephen's talking about, in order to look at people's personal journeys and look at how they recover and what's personal to them and what's meaningful to them. So I think both is required.
Thank you. Elaine, any thoughts?
I'd like to come at this on the positive angle again, in the fact that I'm increasingly involved at meetings at Westminster under a committee called the First 1,001 Critical Days, and that's bringing all parties together and across a whole range of perinatal and infant mental health individuals there and organisations and charities. And I like to feel that government now, in the 11 years I've been doing this, certainly the last 12 to 18 months, I feel these messages are starting to get there, and the fact that these things are worth putting the investment in. So I like to feel that's going in the right direction. The other thing is that quite often when I speak to audiences, I'll get there's nothing in our area, I can't this and I can't that. And it's amazing actually bringing people together in a room and saying, okay, what's in your area? Who do you know who? Yes, you say you haven't a specific perinatal team. Who's a GP in your area? Who else has got an interest? And before you know it, you've actually got a team going there.
Okay.
So I think it is about, as you said, that creativity. and going down instead of the can't do, what can we do with what we've got.
Okay, so thank you very much, Elaine. Wendy, anything you want to add to that?
Look, I think that reduction in services is just something that happens across the globe. Health resources are, well, they're not just finite, they're actually shrinking. And so what we do have to be is innovative. Now, we have to find other ways. And I think what we've done with the notion of recovery is, and to take Leisha's point, is that we need to be more philosophical about recovery rather than pragmatic about what we might actually put in place, because it's about how we engage. And all of this whole conversation, I think, has been about therapeutic engagement, how you engage with people, about all of the things that are important to them, and finding innovative ways to enable them. And so we have an enabling process as we move forward, because we can decry the amount of funding that gets hived off here, there and everywhere, but we still have to work within the system. We have to make it work, and often, because nurses are there 24/7, we're charged with that, and so we should be innovative and creative and find different ways of doing it.
Yeah, undoubtedly nurses are at the forefront of it, and I agree with all that's been said about creativity, and I see some fantastic things going on despite diminishing resources, but I also want to pick up Stephen's point, which I'd like to see mental health nurses becoming a little bit more political with a small p, not necessarily in a particular party, but advocating for our services. I think we've got time for one more question before, just to remind anyone who's listening in, we're getting questions from people who are tweeting them and using the hashtag WeMHNS, short for We Mental Health Nurses, and we will be going to a full Twitter discussion at 7 o'clock. But we've got a question now from someone who's been sent in.
Actually, you're going to get a question from me.
Oh,
and John, actually.
Okay.
So with only 5 minutes to go, what are the obligations of researchers to make sure that their findings are picked up and used by people who can make use of them?
Obligations on researchers to make sure that findings and results are picked up and used by clinicians. Yeah. Wendy, I'm going to go for you first, I think.
I knew you were going to do that. Look, obviously, the whole notion of research is that you disseminate your findings. That's a fundamental premise, that you disseminate. So it's not just about disseminating them in peer-reviewed journals, it's about dissemination just like this, chatting or being able to have workshops in service areas. I think that we can actually work with champions, in inverted commas, to enable the sorts of things that we do. And I think the other thing is that nurses have always been really good at undertaking cost-effective, patient, person-centred research at the point of care, and that's important because then you bring along others in the research journey as enablers for that research to be not just heard and understood but actually implemented. So I think nurses have got a history of doing that very well.
Yeah, very nice, very good. Thank you, Wendy. Leisha?
I think it's coming more to the forefront now, Ben. It's coming more to the forefront now, particularly in the last, I'd say, maybe 10 years, that research findings aren't being implemented, and that's across the board. It's not just for nurses. There's been some kind of seminal papers about this 17-year gap between research being published and it being implemented in practice, if at all. So this whole implementation science area has really taken off, and I just wonder if we need to think about innovative ways of engaging with that a little bit better, in order to ensure that what some of the nursing research findings are being implemented. So I think it's about knowledge transfer, and I think it's about engaging with implementation science models.
Certainly at City University I'm working alongside colleagues who very much approach to implementation science and using theory a lot more to inform our work. And I've got to say it's really helped me think about and develop the way I'm thinking about the way we do this, and it's in a very, very important area.
It feels uncomfortable for a while, doesn't it?
Yes, it does.
It feels uncomfortable because it really challenges what you think about research.
Yeah. Yeah. Elaine, any thoughts on you?
I think coming at this from a non-research background, again over the last few years I've noticed more and more that it's far easier to actually find research out there. I think when I first started on this, it almost seemed to be that every research paper you had to go through a certain login or you had to be in a certain journal. And to actually find it just doing a basic search was actually quite difficult. These days I think it's far more open, and that's got to be a good thing.
Yes, that's a very, very important point, isn't it? Something that, of course, the mental health website helps us do is access good research, and critiques of that research are very, very important. Stephen, any final thoughts on this?
I mean, I'm glad you mentioned the mental health website as well, because one of the things I was going to say is I think it has to be more accessible. And I don't just mean not paying to get access to papers, but just the way in which academic and research papers are written. And I review quite a lot for the NHIR, and one of my frustrations is people who are asked to write a lay summary, and it's full of jargon. Right, so they actually still have not written a lay summary. They've written a lay summary that all they've done is just taken the jargon and make it more simple. But it's not a lay summary. I can't remember what the sort of average reading age of the general population is, but it's something around about 14 or 15.
Well, I wrote a lay summary recently, and I used some of that software that tells you the reading age of the text. And I always think I'm very, very good at it. And it told me I'd written it at degree level. So there you go. It just showed. So that was a lesson for me. We've got 2 minutes left of this discussion, so I just want to wind up and thank our guests, Professor Wendy Cross, Elaine Hanzak, Stephen Pryjmachuk, and Alicia Rennick. Really enjoyed this. Thanks for Ben and John for throwing in questions from our listeners and those who've tweeted. We're going to be going over to an hour of Twitter chat in just a moment with We Mental Health Nurses, led by Mark Brown, who's a lovely chap and very active on the old Twitter. Wrote a fantastic piece this week about personal stories. Well worth a read. Seek it out. Find him online. Go and read it. It's great stuff. This has been a great discussion. I'm really looking forward to the NPNR conference. As I say, I've been coming for far too many years now, but I always leave having heard something that I hadn't thought about before, or stimulating me to go and read something, or go and talk to someone and work with someone. It's a great place to come. It's a very welcoming place, and this has been a great new addition, I think, to the NPNR conference. So thank you for Andre for setting this up. And I'm filling until we break for the weather and the traffic. So thank you, and do join us on We Mental Health Nurses.
Thank you.